Welcome to the Explainer. Today, we're taking high-yield clinical notes and transforming them into your ultimate exam prep cheat sheet for a really rare but completely fatal condition, Whipple disease. We're going to break down the key diagnostic criteria, the sneaky clinical features, and the life-saving treatment protocols you absolutely need to know. Remember, if left untreated, this systemic chronic disease is 100% fatal. So mastering these facts is absolutely crucial, not just for crushing your board exams, but for actual clinical practice. Let's dive in.
All right, let's meet the culprit. Trophorema whipplei. It's a weakly staining gram-positive bacillus, but it's really its behavior that you need to memorize. It's a facultative intracellular pathogen, meaning it likes to hide out inside macrophages. And get this, it has a doubling time of 18 days. To put that into perspective, that is agonizingly slow. It's one of the slowest growing human pathogens in existence. And that sluggish pace is exactly why its clinical presentation is so delayed and honestly, so incredibly hard to pin down.
To guarantee you nail those board questions and actually save lives on the ward, we're breaking this explainer down into 5 quick sections: the deceptive tetrad, systemic surprises, definitive diagnosis, the winning treatment protocol, and finally, deadly traps to avoid. Okay, let's start with section 1, the deceptive classic tetrad. So, the very first step is recognizing how this patient actually walks into your clinic. If someone presents with this exact tetrad of symptoms, we're talking joint pain, dropping weight, chronic diarrhea, and abdominal pain, Whipple disease absolutely must be on your radar. The GI symptoms also commonly include severe malabsorption. In fact, the mesenteric and retroperitoneal lymph nodes can get so swollen that it literally mimics lymphoma on an imaging scan. But here's the catch: these symptoms almost never show up all at once.
And this right here perfectly illustrates why this disease is so deceptive. Look at this timeline. The earliest manifestation is joint pain, specifically a migratory oligo or polyarthralgia that loves hitting the knees, wrists, and ankles. But this arthritis is completely seronegative, meaning rheumatoid factor and ANA are negative. Because of this, it perfectly mimics standard seronegative arthritis. You'll see that it's only an average of 6 to 8 years later that those classic GI symptoms finally appear. That massive delay is exactly where the misdiagnoses happen.
Moving right along to section 2. Systemic surprises, focusing on neuro and cardiac involvement. Okay, you've got to burn this totally unpronounceable buzzword into your memory: oculomasticatory myarrhythmia. Seeing this highly specific sign, which is a combination of convergent nystagmus, where the eyes rhythmically jerk inward, paired with a twitching palate or jaw, is pathognomonic. If you see this, the patient definitively has Whipple disease, no question. It's part of a broader neurological picture that can even include cognitive impairment leading to dementia and supranuclear ophthalmoplegia.
Now here's a truly staggering statistic. 50% of Whipple disease patients have entirely asymptomatic central nervous system involvement. Let that sink in. They might show zero neurological signs whatsoever, yet the bacteria is already hiding in their brain. This makes the CNS the absolute most common site of relapse, and unfortunately, treating it there carries the poorest prognosis.
Plus, do not let a lack of fever fool you. This bug is a super sneaky cause of culture-negative endocarditis, usually setting up shop on the aortic and mitral valves. It's actually responsible for roughly 3 to 6% of these cases. Vegetations are present in up to 75% of patients, but because that classic fever is often missing, standard DO criteria are rarely met. And just to round out the systemic surprises, you might also see uveitis in the eyes or a skin hyperpigmentation called melanoderma in light-exposed areas.
All right, the patient has the symptoms. So in section 3, we ask, how do we prove it? Nailing the definitive diagnosis.
So how do we actually prove it's Whipple? Serology is kind of useless here because the body mounts a really poor immune response. So we need solid tissue and genetic proof. You must memorize this contrast for both the wards and the boards. Histology of a post-bulbar duodenal or jejunal biopsy is your gold standard for classic disease. Under the microscope, the lamina propria will be absolutely packed with foamy macrophages full of PAS-positive, diastase-resistant inclusions. Basically, those are lysosomes just stuffed with the bacteria. But the PAS stain is sensitive, not highly specific. It can flag false positives from mycobacteria and fungi. That's why you need the PCR for its high specificity, making it the go-to for non-intestinal areas. Oh, and you can also use FDG PET scans to help guide exactly where to take those biopsy samples. Now, I want you to actively think about this question. Why must we literally always collect a cerebrospinal fluid PCR on every single patient, even if they have absolutely zero cognitive issues? Well, think back to that 50% asymptomatic rate we just talked about. You must perform it because discovering asymptomatic CNS disease completely changes the duration and intensity of the therapy. Missing it changes the entire course of the patient's life.
Because that asymptomatic CNS disease dictates the whole timeline, we're ready for Section 4, the winning treatment protocol. This two-part protocol is the gold standard for a cure, stepping down from aggressive IV antibiotics to a really prolonged oral regimen. Step 1. You hit the bacteria hard with IV ceftriaxone or meropenem for 2 to 4 weeks. Then, for Step 2, the patient transitions to maintenance therapy using oral doxycycline paired with hydroxychloroquine for at least 1 full year. Just keep in mind, during this treatment, about 17% of patients might experience immune reconstitution inflammatory syndrome or IRIS, and some might even require lifelong suppressive doxycycline.
So if the board exam asked you why we add hydroxychloroquine to the maintenance phase, remember this specific cellular mechanism. Remember how we said Trophorema whipplei loves to hide inside macrophages? Well, hydroxychloroquine actually raises the pH inside the macrophage's phagosome. That alkaline shift directly increases the antibacterial activity of the doxycycline, basically boosting its power right where the bacteria are trying to hide. It's an incredible 1-2 punch.
Finally, we are entering the danger zone with Section 5, Deadly Traps to Avoid.
Look, knowing what to prescribe is only half the battle, right? Knowing what never to give is what actually makes you the expert. In the past, TMP-SMX might have been considered an option, but today, TMP-SMX monotherapy is completely unacceptable. Why? Because the Trophorema whipplei bacteria actually lacks dihydrofolate reductase. That means the TMP, or trimethoprim portion, is entirely inactive against it, and resistance to the SMX portion is super common. Using that, or a tetracycline alone, leads to unacceptably high relapse rates. Don't do it.
And this brings us to a massive warning, literally the most important takeaway in this entire explainer. Glucocorticoids and anti-TNF-alpha agents actively worsen and accelerate this fatal disease. Think back to that timeline. If a patient comes in during year 2 with what looks exactly like standard seronegative arthritis or maybe uveitis, and you confidently prescribe immunosuppressants without ruling out Whipple's disease first, you will rapidly accelerate the progression of a deadly bacterial infection. You are essentially disarming the body's only defense against this intracellular pathogen.
So I want you to keep this final, provocative question in your clinical toolkit forever. Before you write that prescription, have you definitively ruled out Whipple disease? Whenever you're faced with migrating joint pain that is rheumatoid factor and ANA negative, just pause. Have you checked for malabsorption? Have you considered a biopsy? Remembering to screen for those PAS-positive, diastase-resistant foamy macrophages could be the catch that literally saves your next patient's life.